describing as the PSA fine-tuning by risk calculators. I think to avoid unnecessary biopsies and stratify men at risk will be one of the topics we have to handle within the near future. Risk, please, Fritz, we are looking forward to your words.
Okay, well, thank you very much for being invited again to this important meeting. And my task is to speak about the question why we should use risk calculators in diagnosing prostate cancer. It is a subject that is very important because it is likely to have an impact on overdiagnosis, and I think that overdiagnosis is one of the very major, as you will hear in Professor Koning's talk, one of the very major downsides of prostate cancer screening, and it is a top priority for us to try to reduce the overdiagnosis rate. Now, I actually have loaded a slide on new data, but I had a conversation with Jonas Hugoson and decided not to show it. I can only tell you that we do have a 13-year update of the prostate cancer screening study. It is very likely to be published in one of the top European journals. We're in the process of revising a manuscript with relatively minor revisions, and I hope you will be able to read it or see it very soon. If the paper had been accepted, but it is not definitively accepted at this moment, I would have shown you the data. I would like to speak briefly about the definitions that we have been hearing a lot about this morning already, and that is the absolute risk reduction, the number needed to invite, the number needed to diagnose, if you want to, and their definition. And I think we should be very, very much aware that each one of these parameters is likely to be biased. Let me just explain this a little bit. The absolute risk reduction is calculated as the difference in prostate cancer mortality in the screening and the intervention arm, the screening control arm. And obviously, mortality in the control arm may be influenced by various factors. We already discussed that the countries may have a different mortality, so that may have an effect create a difference between countries. But also, PSA contamination may have an effect. If we believe in a mortality reduction, have a high contamination, that will have an impact on the absolute risk reduction. The number needed to invite is 1 divided by the absolute risk reduction. So again, the mistake we may make in calculating the absolute risk reduction is going to be referred in the NNI definition. The number needed to be diagnosed, and that is, in my view, the most important problem we have, is influenced by, is calculated as a multiplication of the absolute risk, as the number needed to invite times the excess incidence. The excess incidence is the difference in incidence between the screen and control arm. Now, that is, we already heard, something that may be very much influenced by bias. For example, the most typical thing discussing the Finnish data, in my view, is that Finland has stopped screening after 3 screens. So the incidence automatically is going to drop. And this is going to create an artifact because it's going to improve the number needed to diagnose and the number needed to treat if you want to. So I don't trust these data anymore, and I think we just have to wait and see how things develop further. Now, fortunately, the RSPC study is not the only evidence we have of mortality reduction. The mortality reduction in the US is substantial, somewhere between 35 or more than 40%. In the Netherlands, we have seen a 22% mortality reduction since 1993, and we have had level 3 to 5 evidence coming from all kinds of observational studies and case control studies, and these we can put aside now. We don't have to use those anymore. And let me just briefly talk about the US mortality reduction and the paper by Etzioni in cooperation between the Seattle group and the another group in the US. They came to these curves, and as you know, prostate cancer mortality in the US rose up to 1993, and then it started to go down. And the question is, what is the reasons for the decrease? People who believe, and Dr. Walsh will say, okay, around this time, radical prostatectomy has become very common, and this is the main reason. Some others may say radiotherapy has been shown to be effective. But this modeling experiment shows that 40% of the reduction, and that is this curve, is probably caused by screening. Now, this is very much helping us in our belief in maybe that screening will, at the end, be applicable to population. So let me speak about overdiagnosis. Start out with the definitions, which I think are very important. We have to be very clear about that. The overdiagnosis is defined as the diagnosis of cancer that would otherwise not be diagnosed during lifetime and not cause prostate cancer mortality, obviously. Dr. Zappa in our group has been the first one who calculated overdiagnosis, and he related it to age. And as you can see, there's a clear trend towards more overdiagnosis with higher age. The same was confirmed in Dr. Draisma's paper of 2003 in JNCI, and he calculated that with the screening regimen we use in the Netherlands, we would have about 54% of overdiagnosis, and I believe that that is probably correct. Dr. Etzioni, in an earlier publication, showed very clearly that overdiagnosis is related to lead time, and there's no question that this is the case. In another study, Dr. Draisma looked at the prognostic factors we're all using in diagnosing prostate cancer in their relationship to lead time and overdiagnosis. And just take a look at Gleason score. Lead time with Gleason score of less than 7, Gleason score 6 or less, is like 3 times higher than the lead time with a Gleason score of 4. And that is reflected in similar differences in the rate of overdiagnosis. So we have to be very much aware of these facts and of these variations in the definition of overdiagnosis, and we have to carefully consider overdiagnosis on the background of prognostic factors. So how could we avoid overdiagnosis? And this brings me to the actual subject of my talk. I believe that we as doctors can contribute to reduce overdiagnosis by applying risk calculators, and I think we should all do it. The best option is to avoid unnecessary biopsies. The secondary option is to use active surveillance once a diagnosis has been made, but it's much better to avoid the diagnosis altogether if we can achieve that, and I think we have good reasons to believe that in the future we may be able to achieve this by the use of MRI and possibly MRI fusion-guided biopsies, and I'll speak about this later, and somebody else is going to speak about it, reporting the allele experience, which is one of the top ones. The example I want to give you is the use of the ERSPC-based swab risk calculator number 3, which gives a biopsy indication. This slide you've already seen. It is the risk calculator, which is available in English and other languages on the internet, and I'm very happy to tell you that there will probably be soon a German version, which will be produced by our Swiss friends here. This is a patient with a PSA of 4, as I have often seen it in my practice. And if you do a biopsy on this man purely on the basis of the PSA 4, his chance of positive biopsy is 21%. Now, if I did a rectal examination, did an ultrasound study, and measured prostatic volume, and found that this man had a normal French rectal ultrasound, no hypoechogenic lesions, no nodules in the prostate, a prostate volume measured by ultrasound of 55 cubic centimeters, PSA is still 4, then his chance of having a positive biopsy would only about 8%. And the chance of an advanced or high-risk disease would be only 1%. So this man with a PSA of 4 in my hands would not get a biopsy, obviously. Now the next guy who comes in has a positive ultrasound study. We see a hypoechogenic lesion. In the same area, there's a nodule on rectal examination. His prostate volume is only 25 cubic centimeters, and you see here that he has a chance of 65% of having a prostate cancer. Again, the PSA is 4. And the chance of an advanced high-risk disease is 47%. So this is the way we can use the risk calculator. Every one of us can do it, and I think we should do it, and avoid the unnecessary biopsies. Now, is this acceptable if we look at it at a large patient group, a group of people who have undergone screening? Dr. Robol has done that and published it in 2009, a paper that is not very frequently referenced. She calculated in a large population of screen-detected cases the use of risk calculator number 3, and she used the probability cutoff of 12.5% positive biopsy. Remember, PSA alone, 21%. So she used a lower cutoff, which made it much more sensitive. She found that this would lead to 33% less biopsies. The PPV went up to 38, and she would detect 14% less prostate cancers. Now, that is the downside. However, of the 240 potentially indolent cancers, only 51 were missed. However, she missed 14 of the 139 progressive cases, and that is 10%. And I think this is one of the reasons why our colleagues are reluctant to use this risk calculator in the same sense, because we don't want to miss the 10%. But you forget, if you decide to do it that way, that we haven't reported any follow-up on these cases, and it's very likely that if you choose for these 14 cases to follow them with a yearly update study, that you will still find this tumor in a progressive state and be able to treat it curatively. So let me briefly speak about MRI, and I will be very brief about this. If you review the increasing literature, the promise is that MRI may selectively detect about 80% of all aggressive cancers. Furthermore, there is a claim that biopsies can be completely avoided in 15 to 45% of those cases that, if they were biopsied, would turn out to have insignificant prostate cancers. However, we still don't have a multicenter study. We still don't have a randomized comparison. And so we're fishing in the dark. I'm very happy that the randomized study is in preparation, and that we will soon see the start of this study initiated in the UK, the United States, and in Canada. This is a typical case that I must say has convinced me quite a bit. It is a man who had elevated PSA. His PSA went up. There was a biopsy. He received 5-hour reductase. PSA went down. PSA went up again. 2 more biopsies, no cancer. Eventually, decision to do an MRI. And the result of the MRI you see here. You see here on the T2 projection a ventral lesion, which is confirmed here in the contrast projection. And then he had a biopsy done on the MRI table, actually in Dr. Jelle Barnes' center, which showed a Gleason 7 prostate cancer. I think, and I hope, that the development should go in the direction of still continuing to do truss-guided biopsies. But the truss-guided biopsies should be combined with the MRI finding, and the possibility that is given to us is to use the truss MRI fusion, which we're doing, also using now in the Netherlands, and I understand is also being used in Göteborg and then probably many other centers, which will allow to use the MRI scan and at the same time give us the opportunity as urologists to keep the biopsies in our own hands, which I think is very important because we're otherwise going to lose a lot of control, a lot of insight into the management of prostate cancer, and we're probably also going to lose patients, which would be a pity. So here are some, well, I'd like to refer to 2 studies on the MRI. This is the Lille study reported by Dr. Hafner, and it has included 555 men with a PSA above 3 to 4. They all underwent multiparametric MRI and MRI guided and 10 to 12 trust guided biopsies. They found 302 prostate cancers, 54%, so it was a clinical material, and 82% had significant disease. 66 of the 302 had a normal MRI and no biopsy indication. However, the trust-guided biopsy found aggressive cancer in 19.7% or 13 of these 66 cases. So there are aggressive cancers missed in this study and in other studies if the MRI decides we don't need to do a biopsy. This is one of the problems we have to deal with, and it is one of the reasons why one of the best studies, and I'm not going to cite that, that's the NCI study reported by Dr. Siddiqui and his group, has concluded that in the future we'll probably continue doing ultrasound-driven biopsies and add the MRI studies, MRI biopsies. I'm wondering how the end result will be. Now, this is the second paper I want to refer to. It is in Press in European Urology. The Brisbane study, 223 men with clinical suspicion of prostate cancer. They all underwent trust-guided biopsies and an mpMRI guided biopsy of suspicious lesions if they had them. And in this study, 63.7% had prostate cancer. The trust-guided biopsy detected 126 prostate cancers, and of those, 47 or 37.3% were classified as low risk. The MRI guided biopsy decreased the diagnosis of low-risk cancers by 89.4%, but missed again, and this is again the problem, 11.9% of aggressive prostate cancer. So we'll have to wait how this all turns out, and I think the best way to give an answer will be to have indeed comparative studies. So in conclusion, on this part, I would like to state that the introduction of population-based screening will depend on a decrease of overdiagnosis largely, even if we show a larger effect on prostate cancer mortality reduction. There's little chance of selective detection of prostate cancer by present or new markers. New markers are on the horizon, but they will need time to be developed, and it will have to be shown to be superior by preference, by adding them to the risk calculator and see whether they lead to a significant increase in the predictions of the present risk calculator. The multiparametric MRI, in my view, is the best future option, and molecular imaging is for the future. So how do we avoid over-treatment? That's the last part of my presentation. We have to realize that there are different definitions of what indolent disease is. Indolent disease, I think, should be defined on the basis of the use of risk calculators. Insignificant disease is defined purely on the basis of biopsy or radical prostatectomy specimens, and the most commonly used criteria are the Epstein criteria. So what Dr. Steyerberg has done, he has repeated the Catan nomogram and used it in a screen-detected population, and he found that instead of 20% of cases classified as indolent in the Hopkins and Texan series, in the screening study there is about 50% of indolent cases, at least in the Rotterdam population, using the Catan criteria. So he has constructed a nomogram on this basis, and the problem of the nomogram is that you have to include a lot of information. You have to have the PSA, you have to have the ultrasound volume, you have to have the biopsy Gleason score, but also the total amount of biopsy of the total length of cancer on the biopsy course and the total length of non-biopsy in the course. So this is information that is not very easily available to everybody. Still, I think the nomogram gives us a very good handle to deal with the situation, and I want to be brief. If we use a probability cutoff of more than 70% of having indolent cancer, then we will have 94% of the non-indolent cancers treated, but we will still not treat 43% of the indolent cancer. Sorry, we will have 94% treated, and we will still we will still treat 32% of the indolent cancers. So the alternative to using this type of a little complicated nomogram is to use the active surveillance criteria, which are constructed on the basis of clinical evidence. And I must say that I've been involved in making the PRIAS criteria. I still remember sitting around the table having heavy discussions about how to best determine which cases can be assigned to active surveillance. And that obviously results in some arbitrary choice, and it obviously results in uncertainties. And these uncertainties can only be overcome with very long follow-up, because we know if we choose very low-risk cases, we will have a large group of men who may have a time to progression that is longer than their lifespan. So these active surveillance studies require very long follow-up, and these long follow-up data are missing. I was very interested to see that Dr. Kloss reported a few days ago in Amsterdam on a 12-year follow-up. But the median follow-up, I think, Laurie, was about 8 years, isn't it? 7 to 8 years. So the real long median follow-up is still missing, and we don't know what the final outcome will be. These are the inclusion criteria of the PRIAS study. Obviously, we need to have proven diagnosis. Patients should be fit for curative treatment. That is very important. That's the difference. It makes a difference to the watchful waiting situation. PSA level of diagnosis should be less than 10. PSA density less than 0.2. This brings in prostate volume, obviously in relation to the PSA. The clinical stage has to be T1 or T2. Appropriate biopsy sampling has to be done, has to be proven. Gleason score has to be 3+3, 6 or less, and 1 or 2 biopsy cores. Not more than 2 biopsy cores should be invaded by prostate cancer, and the participants must be willing, and he must be completely informed. And actually, I think still think that it would be better to have them sign an informed consent. Now, this is the follow-up scheme that is used in the PRIAS study. You can see that here the indications for change of treatment if somebody turns out to have a clinical T3 cancer, or if the PSA goes up to above 20, the metastatic bone scan, and the study will end. And the other criteria are freely available on the internet, and I don't want to go through all the details. So concluding on this, prostate cancer identified by screening are more likely to be indolent in comparison to clinically diagnosed prostate cancer. And these were the figures from Katan and Dr. Steyerberg's paper. 1/3 of the screen-detected cancers can be identified as insignificant. This is purely based on the histopathology of the data, and this is based on the Rotterdam published information. The nomogram can be used to identify men with in whom immediate active treatment can be avoided. And if we use the 30% cutoff that I showed, we haven't seen a single prostate cancer death with that cutoff value. So it seems to be safe with a relatively long follow-up. With a probability of indolent of more than 70%, so far we haven't seen any prostate cancer deaths. That's what I just said. And the alternative to this is to use the active surveillance criteria, as I mentioned. So what are the hopes for the future? I think that the introduction of population-based screening will depend on decreasing overdiagnosis and overtreatment. There's little chance for selective detection of prostate cancer by present or new markers. Multiparametric MRI, in my view, is the best option, and we will have to see. I'm sorry, I didn't turn off my telephone. We have to see larger studies, better studies, more comprehensive studies, and if possible, a randomized comparison. In the meantime, we should use the risk calculator and apply decision aids. And I'd like to refer to this decision aid that Monique Robol and I designed, and that is available on the internet of the SIU and of the Movember movement. And this is the section for the man off the street who wants to consider to be tested for PSA, and it is associated with a document for GPs and another document for the urologist that follows exactly the questions that are that may be raised by the GP after looking at this. And this was my presentation. Thank you very much.
Okay. Questions or comments? I have one short question, Fritz, and it's with these the cancers we detect with MRI, and we say we miss some significant cancer, and it's always that definition, what we mean with significant missed by MRI. And the Hafner study, I think they had quite the criteria for significant cancer were quite strict, I think. You have any comment on that?
There's a lot of discussion going on at this moment what in the multiparametric MRI the cutoff value should be, and I see people here who know better than I do, but the discussion that I've been following is that there's no question that PIRAD 1 to 2 should be considered as potentially insignificant and no biopsy. And PIRAD 3 is under big discussion because that is a mixed bag. And I think this is a major issue for future studies to help us to understand that better. But if there's PIRAD 4 and 5, I think there's no question that the MRI is giving very important information, and the largest proportion of significant cancers are located in the PIRADS 4 to 5 group. Do you all understand what the PIRAD system is, or well, somebody will explain it later.
We maybe come back to it, or probably, so we maybe can, in order to save time, we maybe, but we have one more question up there.
Yeah, Howard Parnes from Bethesda. I want to thank Dr. Schröder for a fabulous discussion of the emerging role of this multiparametric MRI. I'm from NCI, and I work with Siddiqui and those folks that you mentioned. It is really astonishing how the use of this new tool is really enabling us to much more comfortably put men on active surveillance who in the past would end up being treated. And so the question that Jonas was asking is what constitutes high risk in terms of prompting a biopsy, and that's a very important question. Right now, we have sort of a low, medium, and high risk based on MRI features that correspond to about a 20%, 50%, or 90% positive biopsy rate. I'm sure that will be refined over time. But a related question, which I think is even more interesting, is what do you consider a significant cancer when you found it by MRI? And if you find a small Gleason 3+4, we often continue to watch those folks. And just from Siddiqui's paper here, 582 men were underwent MRI, and the upgrading rate was 32%, which is exactly what you see when you take men to surgery. And among those, two-thirds more Gleason 4+3 and greater was found. They did miss 1/3 of Gleason 3+4 or less, and those may be what we're hearing about in terms of missed Gleason 7s, but only 8% missed Gleason 4+3s. So as this technology gets better, I think we'll be better able to target the high Gleason score tumors, and as we get more comfortable with it, be more comfortable watching the MRI detected 3+4s.
Okay. I think in respect to time reasons, and MRI topics in the next session, I will, if you agree, stop now the discussion. Thank you very much, Fritz, once again for this excellent talk.